everybody. My name is Anna, and today we'll be talking about cardiovascular diseases and the impact that they have on Black women in America. So, what is cardiovascular disease or CVD? CVD encompasses a variety of heart and blood vessel conditions, including heart attack, stroke, heart failure, heart valve issues, and arrhythmia. These can lead to side effects and complications, including damage or death to the artery, an inability to pump blood and oxygen effectively throughout the body, which can lead to cell and organ damage, and brain damage, which can contribute to cognitive impairments and an inability to walk, talk, and perform daily functions. When we talk about risk factors and what populations are at highest risk for CVD, there are a variety of factors that we can look at, including gender, age, race, health behaviors, and location. When it comes to gender, there's increasing evidence that the lifetime risk is similar for both men and women for CVD. However, men historically have had higher rates of CVD death under the age of 55, and women over the age of 65 have higher rates of death and heart complications. When we look at race, African Americans are disproportionately impacted by CVD. They are more than twice as likely to have risk factors such as obesity, hypertension, or diabetes, and they are more than twice as likely to die from CVD compared to their white counterparts. Health conditions and behaviors that increase your risk of CVD include diabetes, obesity, diets that are high in saturated or trans fats, sedentary lifestyles, tobacco use, and excessive alcohol consumption. In the United States, there are a variety of states that have disproportionately higher impacts or higher rates of CVD, and South Carolina is one of those states. South Carolina had the 9th highest stroke death rate in the United States in 2020, and it was the leading cause of death for all citizens. In South Carolina, 1 out of every 5 Black adults has diabetes, and that is a risk factor that increases your likelihood of having heart disease by 2 to 4 times compared to somebody without diabetes. When we look at environmental risk factors, there are 2 primary ones, including lack of access to healthcare and lack of access to healthcare, as well as lack of access to quality healthcare, and then food deserts. So food deserts are defined as areas where fresh food and vegetables and fruits cannot be purchased at a store within at least a 1-mile radius in an urban area or a 10-mile radius within a rural area. In South Carolina, 39 out of their 46 counties have food deserts, and this is a risk factor because it contributes to a higher likelihood of having diets with low nutritional value, as well as a risk of food insecurity, which can double or triple the risk of diabetes, which, as we know, is very high and prevalent in South Carolina. In terms of healthcare access, so Medicare provides health insurance coverage for Americans age 65 and over, but the poor coverage and benefits means that this population is spending approximately 20% of their income on health expenses. And in 2018, South Carolina was ranked as the 8th worst state for accessibility, healthcare accessibility, health outcomes, and cost of care. And as a result of the high out-of-pocket expenses, lack of coverage, and delay of care, which are related to cost issues, this contributes to a higher or an increased difficulty in accessing healthcare services and accessing high quality healthcare services for South Carolina residents. Genetic risk factors include the TTR gene and the APOL1 allele. The TTR gene is more common in African Americans than other races, and 3 out of 100 individuals carry this variation. This is a gene that has been found to have a significant association with increased risk of CVD and CVD or heart-related complications and death. The TTR gene variation essentially is resulting in abnormal deposits of proteins in the organs and tissues, which can lead to stiffness in the heart muscles and difficulty pumping blood throughout the body. The APOL1 allele, approximately 13% of Black individuals have this allele, and this has been found to increase risk of chronic kidney issues by 1.5 to 2.5 times. And it's ongoing for that impact on CVD, but it has been found to be one potential risk factor. However, the impact that has on chronic kidney issues also contributes to the risk of CVD because existing research indicates that there's an association between poor kidney function and a higher risk of CVD. Another risk factor for cardiovascular disease is menopause, and some of the symptoms and criteria for menopause include the production of lower rates of estrogen and progesterone, gaining excessive abdominal fat, and experiencing hot flashes and night sweats. Menopause also increases the risk of metabolic syndrome, which is known to be a contributor to a higher risk of CVD and CVD-related mortality. But metabolic syndrome includes having high blood pressure, high blood sugar, excess abdominal fat, and abnormal cholesterol and triglyceride levels. Most women diagnosed with CVD are not diagnosed until after menopause, which explains why the rates of CVD are higher in older women compared to younger women. However, it is possible to go through menopause before age 40, and that is defined as early menopause or premature menopause, which is a defined risk factor for CVD. And some of the contributors to early menopause include smoking, genetics, and poor health during reproductive years. So based on the existing evidence, I chose to make my priority population African American women age 65 or older who are living in South Carolina, United States. So just some quick stats on this priority population. So for this population of women age 65 or older in South Carolina, 55% have been found to have multiple chronic conditions, 32.5% are obese, 92.4% don't consume their daily recommendations of vegetables, 28.9% have a bachelor's degree or higher, and 10.7% live below the poverty line. So in order to support this priority population and reduce the negative impacts of CVD, a multifaceted approach of improved health communication and social support was designed in order to help educate the population, improve quality of care and follow-up processes, increase screening and healthcare engagement, and improve health behaviors and overall health outcomes. So a primary method of helping to support this population and disseminate health information will be a partnership with the clergy. The majority of this population has a strong religious affiliation. Among South Carolina women over the age of 65, 86% of them identify as Christian. 80% of them, and within that population, 80% state that their religion is very important to them, and 60% state that they attend church or religious-related services at least once a week. So as a result, we recommend that healthcare providers and clergy work together in order to increase health utilization, improve health outcomes. During COVID-19, it was demonstrated that involving the clergy in health-related guidance can improve health outcomes. During the pandemic, 77% of Black Americans expressed trust in their health and their clergy's health-related guidance related to things like vaccines and health service utilization. So to improve the communication, a 5-part workshop will be created in order to help healthcare providers improve their cultural humility, effectiveness of communication, follow-up practices, as well as increase the utilization of preventative healthcare and improve the overall quality of healthcare. So when it comes to cultural humility, we will promote empathy and understanding of cultures in order to, because the population is African American, we want to be able to communicate effectively and reduce any biases that may be contributing to healthcare disparities, primarily through an emphasis on equality, empathy, and understanding. And then to improve the overall health communication, we will focus on effectively and appropriately communicating based on factors such as culture, age, and health literacy levels in order to reduce miscommunication and improve overall experiences. We will improve follow-up workflows and improve at-home care in order to reduce readmission rates and disease progression. And then by increasing preventative practices, we will help to reduce the disease progression and development and reduce the overall health burden. And then by focusing on quality of care, we can help to improve health outcomes, improve clinical performance, and implement new safety measures in order to improve health outcomes. So the communication strategy will be a multifaceted approach. Like we mentioned earlier, healthcare providers will partner with the local clergy in order to better understand the perceptions, beliefs, needs, and culture of the priority population. And the clergy will maintain a key role in encouraging healthcare utilization and recommendations within their community, also supporting healthy behaviors among their congregation. There will also be interpersonal messaging, online resource coordination, written materials, and an overall emphasis on improving health communication and efficiency of the medical providers that are working directly with the priority population. Some of the best practices that will be utilized include using simple language and slow speech, following the 7 C's of communication, meaning that all communication within the healthcare field and the follow-up services will be clear, concise, concrete, correct, coherent, complete, and courteous. We'll also emphasize the importance of having feedback and bidirectional communication so that patients have the opportunity to ask questions. And we'll want to avoid information overload, utilize visuals, ensure consistency and empathy, and maintain positive body language. The dissemination strategy will focus on providing health education and verbal health education and recommendations by the healthcare workers and the clergy, using written materials such as pamphlets, posters, and guides that will discuss risk factors, symptoms, treatment options, and resources, and then combining both of those options with electronic strategies, including virtual support groups, telehealth services, and informational social media pages using platforms like Facebook. Some of the dissemination deliverables will include an at-home care guide to help improve the follow-up practices and at-home practices of patients. So these will go over things like medication, diet, exercise, and health behavior recommendations. Other deliverables will include a standardized follow-up workflow to improve processes of healthcare providers working with CVD patients. There will also be a clergy and healthcare provider partnership plan created, and then related metrics that will be measured and monitored to evaluate success, as well as the creation and continued maintenance of the social media pages in order to improve the external health education and resource coordination opportunities, and informational CVD pamphlets and posters that will be posted in healthcare facilities, women's resource centers, and community centers. This is a do's and don'ts infographic where we'll go over what is CVD, some of the signs and symptoms, and then methods that patients can do to reduce their risks and improve their overall health outcomes. That is my presentation, and thank you.